to start recording. So we just started recording, and so I have to say a few words. We're talking about aortic aneurysms today, and I want to welcome you to our recording. Basically, we've talked about the types of aortic aneurysm and endovascular stents in the descending thoracic aorta. That in the ascending, it's very much experimental at UCLA. And abdominal aorta is classified as the juxtaposition with the renal artery or adjacency to the renal artery. And there are stents that can be deployed bilaterally. And today we're talking about the ascending fusiform thoracic aorta first, and the problems and implications of reimplantation of the coronaries with little buttons, and how you get around that. And then we've been presenting a 28-year-old male who was applied for the Tampa Police Department and had an echocardiogram that showed this on a routine echo. And then we talked about the restrictions and the impact of the heart and lung law currently. And then his physical examination was entirely normal. We talked about the anatomical landmarks of the aorta and what are important in both looking at this as well as working at aortic valve replacement. And now, of course, everyone's familiar with the TAVR that we're doing, where it's a transcutaneous or percutaneous technique. And all these landmarks and all these measurements are very important with that. We have, how do you know someone has a dilated ascending aorta versus an aneurysm, and what's normal for people's sizes? And so we have sort of a mean, and we have upper limit and lower limit of normal, less than 50 in males and females, and greater than 50. And of course it's based on body surface area, because if you're 5 foot tall and you have an aorta of maybe 45, that's going to be tremendously big. And then if you're 7'3" and you have an aorta and it's 48, that's not going to be so big for that person. And so it all has to be applied in terms of dimensions. And so it's important to have a nomogram. And there is a nomogram that's in the back of Feigenbaum's book of echocardiography. And so you can go there, print that out, make copies, and keep it on your desk. And then you can place the dot of your patient and see in relationship to upper and lower limit of normal. And so that's pretty important. And then we look at his EKG, and his EKG shows some prominent voltage. Apologize for the quality of this EKG. But there's some prominent voltage, and that's about it. And then here's his echocardiogram where you can make this measurement. This may be on this particular picture, it looks like it was about 54. The maximum was about 57 millimeters or 5.7 centimeters on this particular patient. And this is a picture of the aortic valve, and collagen vascular disease of the aorta is frequently associated with a bicuspid aortic valve. And so this aortic valve is, here's a leaflet, here's a leaflet, here's a leaflet. So it's definitely not bicuspid, it's tricuspid. This is the upside down Mercedes-Benz emblem. And so you can see there are 3 leaflets. And so, but you can see the dilatation actually starts above the valve and then proceeds on, so the sinotubular junction appears to be dilated. Maybe even the sinus valsalva is dilated. And so here's another picture to remind me to show you the echo and the EKG. So let's go to the echo first and see what we got here. And so here's our echo showing the mitral valve leaflet and the left atrium. The left ventricle is beating well, and the aortic valve is here and the aorta is here. So let's see if we can show this a little better. And so usually I can scroll through this very rapidly. So we want to know if there's aortic regurgitation or leakage of the aortic valve, and there's very slight, and we'll show you right there, very slight leakage of the aortic valve. Doesn't really count, but that's what you worry about. If you dilate the annulus, what's going to happen to the leaflets? Well, they're going to get pulled apart, and they're not going to coapt well. And so that hasn't happened in this particular patient, and there's no bicuspid aortic valve, which would predispose to that. So that's a good thing. And so, and here's the aorta, and you can pick different places to measure it in different views. And so we're going to scroll through here kind of rapidly. Here's a nice picture of a 5-chamber view showing the aortic valve and showing the ascending aorta. This is a 4-chamber view. This is left ventricle, left atrium, mitral valve, tricuspid valve, right atrium, right ventricle. So you can see things very well here. And so we're going to continue to scroll through. And there's the tricuspid aortic valve. This is the tricuspid valve over here, looking to see if it has any leakage. Here's the leakage of the aortic valve and how you can see it so well. Bye-bye. And normal contractility everywhere. And now we're starting to get a glimpse of the ascending aorta and how it looks. And then we can measure, say, from internal diameter. We get, in this particular site, internal diameter is 53. We can get different measurements on this, and obviously it would be nice to have some kind of standardized measurement, which we will show you in a minute. And there's the leakage of the aortic valve right there, very slight. So we'll talk about what that means in a minute in terms of repair. And so it looks like we come to the end of that scroll. And you can see, actually, sometimes you can go up to the sternal notch and make pictures here and get some pretty good pictures. And so Ben is becoming very familiar with this technology. And so let's show you the next part, which is the aorta. And so we'll go back to my slide deck, which is somewhere here. There we go, slide deck. And so the next slide shows a snapshot of looking at the ascending aorta in 3 views simultaneously. At the same time, you're looking at a volume rendered image. And so you can see this aorta, ascending aorta, is very prominent there. And then we've got, looks pretty big there. And then here, not as exaggerated. Here it looks a little big. And so let's go and look at, and here we are with a big aorta. And so we can measure this all the time. We can just keep measuring and seeing what size we can get in different views. It's supposed to be somewhat tangential and perpendicular to a tangent. And the tangent would be something coming along like that, and something coming along like this with a 90-degree angle. So while we're there, we have a great opportunity to look at the coronaries. And so a lot of doctors do cardiac caths in people with ascending aortic aneurysms to look at the coronaries, but we can see them with the cardiac CT very well. And the coronaries are looking great, which you would expect for a 28-year-old gentleman, that he would have normal coronaries. And so they look fine. We had a guy by the name of David who was in the military, who had a 7-centimeter thoracic aortic aneurysm ascending. That was a big one, and basically that met surgical indications. And so we made the pictures and showed him his coronaries, and they were beautiful. And we said, you wouldn't want to do a cardiac cath on you, David, to look for these coronaries. I'm glad we have the CT, because the cardiac catheter basically is not quite long enough, and it gets lost in the redundant aorta as it comes across to make the pictures, which I'll show you what that means over here. So if this catheter were coming in, say, the groin, it would come up the descending aorta and then would come around the aorta, and by the time it got all the way around here, down here, and around here, it would pretty much get lost in this aorta because it's so big. And so if it was a number 5 catheter or number 4 catheter, it would actually collapse, and you wouldn't be able to get it to reach over to the coronary, and it might not be long enough. And so we told him all about that, and he was concerned, And we said we don't need to do that. Look, you can see some calcification of the ascending aorta. That's a sign that this is a reactive inflammatory type process because calcification is a result of that. So it's like an aortitis, in fact, if you get this kind of degenerative calcified changes. But that'll all be gone when you take it out. And so there is a piece of calcium up here showing that it's reaches beyond the area we're looking at in terms of some aortitis up in here as well, which is just beyond the left, between the left carotid and left subclavian. It's right there. And so David went to Houston to Dr. Caselli to get his aorta operated on, and somehow a cardiologist was prepping him and ran into him and said, oh yeah, well, we'll have to do a cardiac catheterization. And so he's doing the catheterization. Of course, David's awake during the procedure. And while he's doing the catheterization, David says to the cardiologist, well, you know, Dr. Harrison said it really wouldn't be necessary to do the cardiac cath, and we had everything from the CT. And the cardiologist is mumbling, oh, we got to do this case. We got to look at the coronaries, and we always do catheterizations. And so then as time goes on, Dr. Harrison said you may run out of catheter when you're doing it, and it may not reach. And the guy's mumbling, oh, yeah, I see that. Yeah, we're having a little trouble. We'll get this, you know. And then he said, well, sometimes the catheter actually collapses inside because it won't kind of loop over. And he said, oh, yeah, I've got to change catheters. I'll get a bigger one. And he said sometimes people have to use a multi-purpose, and they have to get a longer catheter, 125 centimeter instead of 110 centimeter. Okay, I got it, you know. And most of the time, very frequently, the cardiologist would just give up, you know, because he can't reach the vessel. David, I wish you would keep quiet during this procedure, you know. And so the cardiologist did give up because he couldn't reach the coronaries. And I don't know why he set about to do that, but David was a wise guy, and nobody loves a smart ass. But anyway, let's move on and look at this. So we got normal coronaries, we got a nice big aorta, and we have actually have a way of measuring this that's a lot better than what we're showing you. So let's show you that, which is called vascular aortic stent. And so there's a technique in our software that makes it possible for us to measure this and make everything perpendicular to a tangent to be able to get good measurements. And look at this. This is all being done without my help. And we can get all these numbers. And look over here, you can see exactly what we're doing in terms of getting numbers at every level. This is for abdominal aortic aneurysm that you see there, but we can get all the measures in the ascending aorta and see everything we need to see, and there it is. And we can get numbers that make sense from one picture to another that are not just numbers that are measured randomly, assuming that you're tangential and perpendicular. And so that's pretty cool that we can do that. And then we just take this down. And as I move that along, all the measurements that are being made up here are the perpendicular. So let's move that along and see. And we got 51 millimeters, 55 millimeters, 57 millimeters. There's 57. And so we're getting close to the biggest part there. Oh, there's a 59. 60 millimeters, bingo. So these are actually accurate, reproducible measurements that we can get from, if you were in India measuring this, so using the same software, you get the same numbers that I'm getting here in Tampa. So that's a pretty good thing. So we use this for our TAVR procedure when we're doing transpercutaneous aortic valve replacement. And so that standardization is pretty cool. Here you can see this reactive phenomenon with calcification. That means this has been going on for a while to get calcification, and it means it's an inflammatory aortitis that's taking place. That this is unstable, and we'll talk about the instability in a minute. Let's go back to our slide deck. Feel free to interrupt if you have any questions. So here's Mr. Pierre Simon Laplace, who is known for the Laplace formula. And you never thought you'd be using your high school or college physics, but here it is again. And it's always, you always got these weights, or you've got a piece of wood, or a lever, or a balloon. And so it all can be explained with all those things. And so we're interested in pressure inside here is the same. And so we're holding the pressure constant. And what's changing is the radius. And you can see small radius. This is a sphere, and this is cylindrical. And we're interested in the maximal wall tension, which the formula is tension equals pressure times resistance. And so if you hold the pressure constant, the tension, that's not resistance, excuse me, that's radius. And so if you hold the pressure constant, as the radius increases, the wall tension is going to go up. And wall tension is basically what's supporting the fact that this might rupture at some point when it reaches a critical radius. And so you can see on a cylinder, there's a different effect than there is on a sphere, because on a sphere, it's about half of the wall tension that there is on a cylinder. So greater tension here, lesser tension here, and then much less tension here. Very little tension. And so, and then as you put more pressure in, this will expand out, and you'll have a full balloon. And then you can take several of these and make a dachshund. And so, so this is Dr. Laplace, or Mr. Laplace, and his famous formula. This is what we think about when we think about what's going on here. So tension equals pressure times radius. And you can see it's not the radius squared or the radius to the fourth or anything like that. It's just the radius. And so, hey, so we can actually find out the risk. This is a very important table. And this table is in JACC journal. It's a few years old. And it tells you about the risk of rupture or dissection. And pink is low risk. And this color, light shade of green, is moderate risk. And this dark shade of green is high risk. And so this is based on body surface area compared to the aortic size. And so we got body surface area this direction, and the abscissa, we've got the ordinate, we've got that, and the abscissa, we've got the aortic size. And so you can see as the size goes up and the body surface area goes down, that there's greater risk. But as the body surface goes up, then we're applying this aorta to a larger person, which means it's more proportional, which means the pressure is the same, but the tension is reduced because it's distributed over a greater area and a greater person. And so we come over here, this is all very low risk, and we can plot our patient in here, Ben, and we did plot him, and we found that his risk is less than 4% per year. And we have people with 6-centimeter aortic aneurysms, thoracic aorta, and people are getting very upset at this 5.5, 5.7, 6. But you can see if you're a 6, as your body surface area gets bigger, your risk reduces. And so we have people that are 6 that are very low risk. And so you see doctors all the time, oh, he's got a 6-centimeter aortic aneurysm, we got to operate. Oh, we can't operate, he's inoperable. This is very dangerous, he's going to rupture. She's going to blow, Captain, she's going to blow. When in fact she ain't going to blow. She only got a 4% per year. And actually I make calculations even more in depth than that. And I've got somebody that has a 2.5% risk per year, and everyone is panicked about him. And what are we going to do? It's a very notable person, and what are we going to do about his surgery? And it turns out, that we've sat on him for a year and a half now, and he's doing fine. And he can't have surgery because he's 85 years old, and he basically has a lot of frailty. And so we haven't done surgery, and he's doing fine. Of course, we like to have some control over this, and the control that we can have, we can't reduce the radius, but we can reduce the pressure. And if we can reduce the pressure, that reduces the tension. The other thing is the heart is pounding against this, and so we can reduce the pounding with a beta blocker, which drops the rate of rise. That's the dP over dt is the rate of rise of that pressure. And so the pressure will rise slowly instead of rapidly, so it's not such a pounding. And then if we decrease the number of poundings per minute, that means decrease the heart rate. We can use a beta blocker for that, or we can use a drug called avobradine and decrease the heart rate, and so there's less pounding per minute, and so it should be less chance of rupturing the aneurysm. And so, you know, somebody has said once, a wag or a sage has said that you only got so many heartbeats in your life. And, well, in this case, it might be true. You might have so many heartbeats in your life. And so if we slow them down, then we might be able to keep from pounding it so many times. And so it might be true only in this case. And so what are our options here, Ben? And so what we're looking at is you continue as you is, and we watch you for a while, and you get yourself a new career as at a desk somewhere, and we measure it every 6 months, and we put you on a beta blocker, put you on an ARB, which is a blocker for angiotensin, and so we put you on an ARB, and so the rupture risk is only 4% or less. Surgery risk is 2%, but let's just wait for it to get bigger, okay? And so that seems like you're sitting on a powder keg with a short fuse and just waiting to get lit. And so there is some activity restriction that you can find from the American College of Cardiology through the Bethesda conference, and we looked up those numbers and found out what you can do, what you can't do. Or they can hold your position in the police department, and you can have surgery, go through rehab, and apply in the next group and get your job that you want, which is your dream, right?
Absolutely.
Okay, so, and your dream hasn't been shattered by Dallas or by Baton Rouge?
No, sir.
Okay, so we still got the thin blue line protecting us. That's all there is between us and criminals. So we're glad you're making that decision, you know, especially somebody nice as you are. So teammates, Chris Wilcox and Jeff Green of the Boston Celtics, you know, had ascending aortic aneurysms, and that meant a lot to them. And so this guy meant $1.32 million a year for 11 years, and this is another $15 million contract. So it meant a lot of money that these guys could take these round objects and drop them into little holes. And so that was pretty important to them and a lot of other people. And so they actually went to Cleveland Clinic, one in January and one in March. And Jeff was in January, Chris was in March, and Dr. Lars Svensson, who's chairman of the Department of Cardiology, did procedures on both of them, and they were fine, and they went back to playing basketball full court, and you know how exertional and contact that is. So it seems to me that if you can do that, and it's okay, that you can go back to being a policeman, sit around the car some, eat some donuts, you know, every once in a while you might chase somebody. And so it seems like, you know, that would be a lot less exertional than these things. But you got to remember, police department, there's a lot of stress. And there's a lot more stress today than there was yesterday, and then there was last week and a month ago. And so we've got to all keep that in mind. Well, what is happening here in terms of the aorta, and when do we reach a critical point on Laplace in terms of this balloon not quite holding the pressure in it? And so it looks like with the ascending aorta, we reach that critical point at somewhere around 6 centimeters. And look at that. Isn't that interesting? We're going along like this, and there's no risk. This is sub-risk. I don't know what that means. That means you don't have hypertension, I guess. And so you got sub-risk, and then you got risk of 0, And then you've got this little increase. This is that 4% we were talking about per year. And then boom, it reaches a critical point, the magic number of 6, and now we've got a 30% rupture rate, risk of rupture. And then the descending aorta, I don't know why it's different. It's anchored differently. But the descending aorta, we've got, I don't know why this is like that. But then let's go over here, and we see an incremental increase in risk. This doesn't make any sense. Incremental increase in risk, and then all of a sudden at 7 centimeters, boom, it jumps up. And so this is the magic number on the descending thoracic. This is the magic number on the ascending, and we don't have the abdominal in this calculation. But let's look at the surgery that's anticipated. And Dr. David basically took this and puts a Dacron graft in, and then takes these little buttons that he makes of the coronaries and basically inserts them and sews them in there. And so hey, that's chop off the aneurysm, not very hard to do. Sew in some Dacron, that's easy. Sew in some more Dacron, that looks pretty simple too. But these little guys that's kind of different. That's a little more fine surgery. And it's how you cut the button, how big the button is, and whether this is actually coming out at a right angle or where it's coming out, obliquely or acutely. And so those things are pretty important, and whether you mash this a little bit and submit it to some trauma is pretty important. So this is the David surgery, or David surgery. And then Yaqub is a guy from the Middle East who practices in London. He's getting towards retirement age now. Basically did this little thing where he has a little bit difference in the cusp. Whereas this came over these little cusp, this fits right into it and has this little round area, semicircular, semilunar area, and then puts the button into there. And so that's what Yaqub did to make it a little bit different. And then this is our guy, Dr. Martin, and this is the sleeve. There's a little slit here, and he basically brings this over and brings it up into the little slit and then closes it. And hey, that looks pretty neat to me. I can see where doing that instead of resecting this and having these little buttons and sewing these little buttons in seems a lot easier to me too. And so I think Dr. Martin found a good shortcut in how to do this. So I like that. So the Florida sleeve, we have some slides on that. Let me show you the Florida sleeve. And so this is the Italian adaptation of the Florida sleeve. They don't call it Florida sleeve there, but they do attribute it to Florida later on here somewhere. The Florida sleeve. So in 2006, to make the David operation easier, we introduced a new technique sharing the Florida sleeve concept. So Dr. Martin was very humble, not calling it the Martin sleeve, like Dr. David and Dr. Yaqub were a little boastful. And so we like Tom. He's a good guy. He's an humble guy. And so the surgical technique and these people's experience, and this is how they're doing it, where they're resecting the aorta, they're using cardioplegia, and they're making 2 little keyholes, and here we go, and this is the way of using the sleeve, and it just slips right over the coronaries, and it's right in there, and then you can make sure that everything's okay. He's about ready to slip it over here, and there it slips over, and then you can put some sutures in there and tighten that up. And so here's a video. They have a video case. This is the ascending aortic aneurysm, and they did the sleeve on 90 patients. They had some people with Marfan's disease, bicuspid valve, some dissection. The mean aorta was 53, body surface area 1.93, mean age 61, 26 to 28, so you're not an outlier. And here's the type of prosthesis that was used. Prosthesis diameter, annular stitches, the original Florida sleeve, and this is everyone's got to have their own little technique. So to get their name on it. So the Bergamo Lecco, instead of the Italian sleeve, is purporting to have less suture material, less sutures. And then the keyholes are small. This keyhole is bigger because they've got these little radial things on the keyhole. So let's go back and look at that. Yeah. They've got these little things here, little radial things coming out. Instead of making a big keyhole, they've got it so it's expandable. Whether that's an improvement or not, I don't know. So let's take a look at this. And there's the sizes. And there's showing the aorta that was modeled with a CT scan. And the sleeve, compared with other techniques, appears easier to perform. It seems less difficult to fix the cusp in the right position for a good valve confidence. No contact between the leaflets and the graft. A normal design of the aortic root is preserved. A longer follow-up is required, and they don't have that. But that's what they're saying. So then we've got actually a little picture of the Florida sleeve being performed. And let me see if we can play this.
Mild to moderate eccentric aortic insufficiency in a patient with bicuspid aortic valve and ascending aneurysm. Here we have dual arterial cannulation. The innominate artery is cannulated through an 8 millimeter graft, and the aortic arch itself beyond the left common carotid artery. Here we're exposing the innominate and left common carotid arteries and see the cannula distal to that. Next, we are dissecting the aorta a bit further between the innominate and left common carotid, and we'll pass a umbilical tape between these arteries, which is going to help guide cross-clamp placement. Here is a clamp being placed at the base of the innominate artery after we initiated cardiopulmonary bypass, and a second clamp angled in between the innominate and left common carotid towards the subclavian. We've given custodial cardioplegia, and we're transecting the tubular ascending aorta to take out the bulk of this aneurysm, which is dominant in the tubular ascending segment and less involved in both the root and the aortic arch. Next, we're going to get a great look at this type 1 RN bicuspid aortic valve. Here you can see the conjoined leaflet. The right coronary ostium is about 12 o'clock on the screen. Because of restriction and mild aortic stenosis, we're taking off the raphe, which is called raphe shaving. We're just starting this with a Metzenbaum scissors, taking care to siphon off any dropped calcific debris. And once we've cut off as much as we can, taking care not to injure the leaflet or create a perforation, we're going to take a pituitary rongeur and clean up any rough areas to smoothen it a bit. And now the leaflet is much more pliable. Here we're dissecting the aortic root out externally down to the crux of the heart, basically the aortic root attachments with the left and right atriums and right ventricle circumferentially. In this case, because it's a Florida sleeve, we're leaving the coronary origins intact. We have to take great care near the origins, which are identified both from the inside and out. And we're taking this dissection deep down to the external aspect of what we are characterizing as the virtual basal ring beneath the aortic valve leaflets. Here we're passing the right angle clamp under the left coronary artery and passing in a vessel loop. We do this similarly under the right coronary artery, and this will facilitate placement of the graft in certain sutures throughout the procedure. Next, we are going to be placing anchoring sutures in the virtual basal ring underneath the aortic valve and externalizing these sutures outside of the aortic root tissue. Very similar to a valve-sparing reimplantation procedure or David procedure. In this case, we used 4 anchoring sutures, and once the sutures are passed, we're going to pass them through our graft, which was specially created for the procedure. There are slits that correspond to the area of the coronary arteries, and this graft can be made with these slits after this dissection has been completed, so they're placed correctly. Difficult to see here on the right coronary, but much easier here on the left coronary. You can see limbs of the slit which are being passed down to the left and right of the coronary origin itself, and these are anchored with the Ethibond sutures. Here we're placing a 27 millimeter valve annular sizer dilator because the annulus itself is slightly larger than this, around 29 millimeters, and we wanted to reduce this annulus slightly because of the aortic insufficiency and give ourselves an opportunity to build leaflet height in the conjoint leaflet, which is likely contributing to the eccentric aortic insufficiency. Both under the right and left coronary arteries. Here's the left coronary artery. We're passing a fluoroproline suture simply to close the limbs of the slit underneath the coronary artery. We're passing the suture in a mattress fashion with the blunt end of the needle underneath the coronary artery. And in a moment, we'll be able to see tying the suture down on one side of the coronary, and again, taking great care to not snare or trap the coronary artery itself. And this is actually straightforward. Once we're finished closing the slits under the coronaries on either side, we're going to anchor the commissural areas of all three aspects of this bicuspid valve. The RN commissure is, of course, a bit lower than the others, and this is simply suspended at its anatomically correct location. Trimming any excess graft for the inclusion of the aortic root, and simply passing over and over proline sutures to complete the sinotubular junction anastomosis to the included aortic root. Notice that the conjoined leaflet now has excess tissue that needs to be tightened up. These are with sutures next to the nodulus aurantius. Next, our attention is directed to the distal anastomosis. This is the hemiarch anastomosis with the lesser curve aspect essentially opposite the subclavian artery. And here is the completed anastomosis. The aorta is being unclamped and reperfusion is being initiated. Graft-to-graft anastomosis roughly at 11 or 12 o'clock, looking quite well and rather hemostatic, as is usually the case. And finally, we look at the completion echo, which shows no residual aortic insufficiency and a valve that had single-digit gradient.
Piece of cake, huh? Don't you think, Ben? Piece of cake. So it makes it very graphic and very simple. So let's move back to our slide deck for a minute. And so you know the sleeve. I like the sleeve. I think it's really a good technique. And so I'm glad we got to see that. I thought we'd take a minute to talk about abdominal aortic aneurysm, and we actually have 7 minutes. So as classified in position of the renal arteries, and you can see how they're named. And then we were going to talk about a gentleman who's not here today, who has had a 61-year-old gentleman who came to the ER with lower abdominal cramps, and basically he had a known infrarenal abdominal aortic aneurysm that was 7.4 centimeters, which is a biggie. Of course, he had hypertension, which is very common with aneurysms, and so he was on nifedipine and diazide, drugs that I wouldn't have chosen. I certainly would have used a beta blocker and an ARB. And so this is his EKG when he came into the emergency room. He's got some poor R rate progression here that may be an old anterior wall MI. Usually it's classified as anterior septal, but the MRIs on people like this actually confirm that it's apical, not anterior septal, but that's the way we read the EKGs traditionally. And he had an echocardiogram that showed LVH because he had long-standing hypertension. And here's a big aneurysm, abdominal aorta. Looks like that on the CT scan. And of course, you worry about coronary artery disease in people like this, and he did have a fixed apical defect. Here's this in his nuclear scan, and the bottom is rest, and the top is exercise. This is rest, exercise, rest, exercise. 3 different views of slices, tomograms. And there's a big bite out of the donut that you see in septal, anterior, apical, and here apical, apical, and the bite out of the donut seems to be pretty much the same during rest as well as during stress. So you would call this an old anterior apical septal heart attack that he did not know that he had a heart attack. And 40% of heart attacks, according to the Framingham study, are not diagnosed at the time of the heart attack. You might have a little heartburn or something. So he took off the apex sometime in his life, but it looks pretty stable by a SPECT scan, what you and I know, SPECT scan is worthless, and we could have figured this out. A better detailed look at his echo at the apex and could have figured that out. So missed it on the echo, should have been seen, and this we'll see how much help this was later on. And so a subsequent course is that his pain went away. He was scheduled for surgery on the 4th hospital day, and I got called to see him when he's basically in the pre-op area and is in duress and has a blood pressure of 60 systolic and a heart rate of 120, and basically ruptured his aneurysm waiting for getting prepped for surgery. And so that's a fire drill, hopefully not a Chinese fire drill, but it is a fire drill. And so as it turned out, his surgeon wasn't here yet. And so here's a guy in pre-op with a ruptured abdominal aortic aneurysm without a surgeon in the house. And so we're going to take care of him. And so the anesthesia was extremely prompt, jumping on him, and I was there. And so as we were taking care of him, all hell broke loose. And so we're intubating him, we're putting on vasopressors, we're giving him a couple units of blood really quickly because, you know, how much Levofed did he lose? He didn't lose any, he lost blood, so he's got to get blood. So meanwhile, while we're doing all this, he's developing tombstones across the anterior wall with severe ST segment elevation. This is an inferior apical left ventricular acute STEMI by all definitions. And so now he's got a STEMI, and he's got ventricular tachycardia, and he's got a systolic pressure of 60, and he's bleeding to death from abdominal aortic aneurysm. I do want to look at his abdomen a little bit, and I call for a peripheral ultrasound to come over so we can take a look. And basically they tell me on the phone, no, we can't come. There's no data entry of a request in the computer. And so we can't come unless you enter a request in the computer. So I hang up on them. And so now we got to get this guy out of here. And so we're going to go downstairs to the emergency room because we can't do him here. We don't have a surgeon. And so I'm not going to do it. And so we're going to take him to Tampa General. So we got an ambulance on the way from fire rescue. And I've got a really good nurse helping me from the ICU. And so we're going to go downstairs and be waiting for them in the ER so that we don't have to take a lot of time. It takes a while to get down the elevator. It takes a while to move all this stuff. And so that's our plan. So we get everything ready to move. And we're right ready to move. And there's a nurse at the end of the bed that's blocking the way with her arms crossed saying, no, doctor. And I had talked to the ER, and the ER doc had cleared it. But this nurse is head of the ER. And she says, no, it's too much paperwork for me if you go to the ER. So we plow over her, and she's got gurney marks on her tummy as we move by, and head for the elevator, which we had somebody get the elevator. And then fire rescue's here, and some firemen are stomping around with their outfits on. And they came from the pumper. They came over to help us. And then we got fire rescue, so then we get in the ambulance. And meanwhile, we're on our way, and I give this EKG to one of the fire rescue guys, and he puts it in his back pocket. And we're on our way, heading over there to Tampa General. We talked to Tampa General. We talked to the surgeon who's on his way, and he said, well, he'll meet us at Tampa General. We talked to the surgeons at Memorial and asked them to meet us at Tampa General. And so we talked to the ER doctor at Tampa General. Everybody's been talked to, and we show up there, and then the patient is turned over to the ER staff at Tampa General. And then they proceed to want to do a CT scan to see if there's really an abdominal aortic aneurysm and reconfirm the diagnosis. Meanwhile, there are a couple kids running around who are junior faculty cardiac surgeons who say, oh boy, we got an aneurysm coming in. Yeah, it's an abdominal aortic aneurysm, acute rupture. Oh, that's great, I can't wait. And so the senior surgeons that we'd called over to be ready, they see these enthusiastic guys, you know, fools running in where angels fear to tread. And so these guys sort of disappear because they say the kids are going to take care of it. Let's get out of here. So they're gone. We did talk to somebody about putting a stent in. That guy disappears too. And so then we got the young guys upstairs, and then our surgeon who was supposed to do the surgery here shows up, and then he's a senior guy. He's going to go up and help the young guys. And so somehow they're successful, and they complete it. And the patient, this is the echo that we did before we left Memorial for Tampa General, and he gets transferred, and everything comes along pretty good. But they forgot to give the EKG out of the fire rescue guy's back pocket, showing these acute changes. And so the guy's now ready to be discharged from the hospital, and I call up over there and remind him that he had this. And so now we get a cath doctor in, and he's going to do cardiac cath on the patient. And let's take a look and see what we found on the cardiac cath over here. Hang on just a second, and that's. But in the cath, there was a fuzzy area in the mid-LAD, and that was felt to be the culprit. And so we took care of that, and he got a stent. And, oh, here. So let's move on then, and we'll show you that another time. Sometimes they get the names backwards. And so when they get the names backwards on the header, then the names switched around, and we can't find it. So just to tell you, to reiterate what our experience has been in terms of abdominal and thoracic aortic aneurysms, this is sort of in conclusion that I've seen acute presentations on acute ruptures about 4 times. And here's a guy that came into the ER and had abdominal pain and some back pain and was seen by his doctor, and they felt like he'd eaten a bad sandwich. And so no big deal. And so, but his wife snuck around to the phone and called a cardiac surgeon at St. Joe, who called me, and I came in with my echo machine and found aortic regurgitation and ascending dissecting aortic aneurysm. And so I sent him with his bad sandwich problem to Tampa General for immediate surgery with Dr. Angel. And later, like 10 years later, he had another dissection, and Dr. Tom Martin fixed that at Florida Hospital. And you'll see that we'll be mentioning experts from around the country that are the best people at doing these things. And then we had a lady on 2 East, who's 38-year-old retarded lady who had a leaky aortic valve and a dilated ascending aorta. And I got called by 2 East from the office by a nurse by name of Kim, who said she's gone into menopause. And I said, how do you know that? And she said, well, she's really sweating a lot, so I think she's hit menopause. I said, it sounds kind of an acute onset of menopause. This lady now is selling drugs, and so she's on our farm rep, so which is a good placement for her. And so I went running over there, the nurse that is. So I went running over there, and we shipped her out to Tampa General, and Dr. Angel did the surgery and saved her life. And I saw the family 10 years later. They came by to say hello and say how grateful they were and how she's doing well. And then we got this guy who had a type 1, which, as you recall, goes from like stem to stern. And basically, he was for medical treatment. You couldn't replace his entire aorta. And he's doing fine. I saw him the other day. He rode over to my house on his golf cart, and we went for a ride together to talk. And so he's doing good. And then we got this gentleman who basically is in his late 80s and has a 6-centimeter type 2 aneurysm, and his risk of rupture is 2.4%. We really calculated in detail on him, and so we don't have to worry about him. We're just treating him medically, and he's doing fine. And this lady, we saved her. So we got some people, conservative treatment, we got some people, but this is what happens in the course of a 40-year career, waltzing around emergency rooms and seeing patients. And so then we have some indirect type things. Here's a sub. This is a guy by the name of Tom who had a culprit lesion in his coronaries and got angioplasty and stenting, but he wouldn't go away. He kept having pain. The pain was the same, and he was having this chest pain. And, you know, you can't just dismiss that and say, hey, it looks like everything's okay there. And so we said, well, let's take a look at his stent. And let's take a look at the ascending aorta at the same time. And we did, and we found a little ulcer in his ascending aorta, which would have killed him. And so we sent him to Dr. Caselli, who's in Houston, who did a deep branching procedure, which is huge. You replace the whole aortic arch. You got all the branches hanging, and then you put the dicron in, and then you put them all back again. And so that was cool. And then here's a guy, William T., who was 84, who had a bleed into an ulcer of his aorta. And so that's an acute aortic hematoma. And we managed him medically, and he's done fine. And here's a guy who had a homograph in the ascending aorta and had it replaced 10 years ago. And the homograph fell apart, and now he had to have surgery for aortic regurgitation. And so we sent him to our best, who's Dr. Caselli. He's excellent. He replaced Dr. Cooley in Houston at what is St. Luke's. St. Luke converted from Episcopal to Catholic recently, but it's still St. Luke's. And so because he's old, he had a 55-day prolonged post-op hospital course, but I don't think he would have done well if he hadn't gone to Dr. Caselli. And here's a guy by the name of David we talked about with the 7-centimeter ascending aortic aneurysm who went to Houston, and the colonel, he was in the Air Force, and the colonel argued, we don't want to send him there. It's going to cost too much money. And what do you mean? Why don't we just do it here locally? And I told him, well, we only want the best for our Air Force guys. And I said, it's probably cheaper if you check on it. So he did check on it. He called back, hey, let's send him out there. It's cheaper. I said, okay, you've got your priorities. I got my priorities. It looks like they're in alignment. So we did send him out there. And thank goodness, because the surgery was a piece of cake. Everything went well. But the next morning, his temperature started climbing to 107 degrees in an hour. And so it happened to be at 5 o'clock in the morning when Dr. Caselli and team were making rounds, 5 o'clock. If you want to have breakfast with him, you got to meet him at 4:30 at St. Luke's. So they're making rounds, and they stumble on this, and they cool this guy down with ice and intra-aortic cooling, abdominal aortic cooling, and get the guy cooled down just great. And he survives, and he does very, very, very well. He was out of his head for a while because of some brain edema, but he survived, and he's doing great now and has normal IQ. And great guy, lives in Raleigh now. And this is somebody by the name of Anthony that we sent to Dr. Badwar, and unfortunately the aorta was resected and the aortic valve and reimplantation of the coronaries, and the reimplantation didn't go well. And when he got home, he was mowing the lawn, had acute inferior wall MI, and we brought him to the hospital, and unfortunately he didn't make it. We couldn't get him out of ventricular fibrillation. And so the reimplantation of the coronaries can be a significant problem. And this was done by a pro. And so obviously something didn't quite sit right, because the day he got back, he had inferior wall hypokinesis. And so we knew what was wrong, and we thought we could weather it until he was better, because to go back in and do surgery again would have been a very, very difficult task. To try to align that with a osteo stent would have been a big problem too. And so we decided to treat him medically, and it didn't go well. And so, and then we've got these guys. This one has a family history of everybody in the family getting ascending aortic aneurysms and bicuspid aortic valves, and then his son having Marfan's. And so it's a complicated, his daughter playing volleyball, and we checked her out because she's very tall. And Duke Cameron is the expert at Marfan's surgery at Johns Hopkins. And so he had surgery there and did very well. And then here's somebody we're following with MRIs to get less radiation. And then you saw the patient that we talked about. And here's a lady with abdominal aortic aneurysm with severe COPD. We didn't think that she would be a good surgical candidate because of that. And they said, oh, she's a candidate. And they measured aorta and said she's going to go to surgery. And I went and remeasured. And again, there's problems with measuring it. You got to get that tangent. You got to get perpendicular to get the right numbers. We measured, and she wasn't a surgical candidate yet. And so saved by the bell. But unfortunately, she did get constipation on one occasion, showed up to the ER with constipation, and they jumped on her with surgery. And said, oh, look, an aneurysm. Hey, this is good. And they operated on aneurysm. She died of COPD. And so unfortunately, she was out of my hands. And so I wasn't able to save her from that. So these are some of the struggles that we've gone through with some of their patients. So some pearls basically echo in the ER is very important for chest speed evaluation. And so first thing I do in the night when I'm called over here is to pick up the echo machine and head to the ER with it. Well, you should have one just hanging around the ER. But anyway, small ER here, so that's what I do. And then always measure the aorta yourself. You know, you can use the stent program on the workstation. It's extremely useful. Triple rule out is when we're ruling out pulmonary embolus, coronary artery disease, and dissecting aortic aneurysm. And you have to gate that because you're going to look at the coronaries and you can't have the heart motion. And so if you gate it to the EKG, then that'll take out the heart motion. And frequently, an aorta in motion looks like a dissection because you see one spot here and then one spot here. So, oh, look, there's two walls. And so somebody got operated on Tampa General a couple years ago with that because of wall motion. And you get inside and you say, oh, look, normal. And then you got to close up again. It's very embarrassing. And so all you have to do is make sure that radiology gates the study when they're looking at an ascending aorta, looking for an aneurysm. And then nobody's going to have a dissection unless they have a D-dimer that's positive. So there's your ace in the hole, is the D-dimer. So that's the pearls from the day, and that's our review of aortic aneurysm. Thank you very much, and we're glad that you could come today, and we look forward to next week. Bye-bye.
Thanks, Dr. Harris.
Bye. Thank you.
Bye.
Bye-bye, guys.